Hello, everyone. My name is Scott Perkins, and I will be your presenter for today's CE presentation. This is Infarm CE Masterclass series, where the goal is to eliminate redundancy in drug information and to really drive home evidence-based care. This is all derived from the fact that if you're a provider and you're asking questions to Infarm, there's typically about a 40% chance that the question that you have has already been asked by someone else. And so in order to kind of get ahead of the curve, to provide information before people have those types of questions, these CE programs have been developed. Now, if you do happen to have a question that you'd like for us to research and to provide in a CE, please feel free to reach out to Janvi at infarm.com. That is JANHAVI. We would be glad to consider your topic for a future CE. This particular topic has been put together by 3 individuals. Janvi, who is a director of brand development at Infarm. She did much of the content creation for this presentation. Yutong is a drug information specialist that works at Infarm, and she's kind of worked in a liaison role in developing this content, these slides. And then myself, I'm the co-director of drug information at Campbell University College of Pharmacy and Health Sciences. And I'm also a clinical associate professor at the institution as well. And I'll be presenting today and putting this production together. Before I begin, I do want to say that neither Dr. Punyarthi, myself, or Dr. Yang have any financial disclosures that are relevant to the presentation of this material today. The topic for our CE is Terlipressin superior to Noradrenaline in the management of acute kidney injury in acute on chronic liver failure? Our learning objectives for today include identifying the clinical characteristics of Terlipressin, to identify current therapeutic approaches to hepatorenal syndrome, to describe strengths and weaknesses of applicable medical literature regarding Terlipressin, to recognize positive and negatives of using Terlipressin in clinical practice, and finally to discuss the clinical applicability of using Terlipressin in clinical practice. With those objectives out of the way, let's begin the presentation. The hepatorenal syndrome is a condition in which a patient's renal function becomes impaired in conjunction with advanced liver disease and cirrhosis due to portal hypertension, which results in hemodynamic dysfunction. There are 2 categories of the hepatorenal syndrome. Type 1, or hepatorenal syndrome with acute kidney injury, is characterized by a rapid decline in renal function and is usually triggered by a precipitating event. Hepatorenal syndrome due to acute kidney injury is associated with a high mortality rate. When left untreated, 3-month survival rate is reported to be around 20%. Now, Type 2, or hepatorenal syndrome with chronic kidney disease, is characterized by a steady, progressive decline in renal function, refractory ascites, and sodium retention. Compared to Type 1, Type 2 hepatorenal syndrome generally has a better prognosis. Risk factors for developing hepatorenal syndrome are those commonly associated with either hepatic or renal dysfunction, including bacterial infections, surgical procedures, cirrhotic cardiomyopathy, use of nephrotoxic medications, diuretics, gastrointestinal bleeding, and alcoholic hepatitis. Hepatorenal syndrome is diagnosed by ensuring other causes of renal failure in patients with advanced liver diseases are ruled out. It's a diagnosis of exclusion. Generally, diagnostic criteria include the doubling of serum creatinine from baseline in less than 2 weeks. Definitions for acute kidney injury in and of itself are variable. For instance, the International Club of Ascites Acute Kidney Injury Network and Kidney Disease Improving Global Outcomes, or KDIGO, define acute kidney injury differently. Sticking strictly with KDIGO, acute kidney injury is defined by an increase in serum creatinine by at least 0.3 milligrams per deciliter within 48 hours, and increase in serum creatinine to 1.5 times baseline within the previous 7 days, and urine volume of less than 0.5 milliliters per kilogram per hour for 6 hours. The first step in managing hepatorenal syndrome due to acute kidney injury is to discontinue medications that could be causing reduced renal function, or reduce the use of these agents if discontinuation is not possible. Patients also receive vasoconstrictors plus albumin. According to the 2021 guidelines from the American Association for the Study of Liver Disease, AASLD, first-line therapy for patients with hepatorenal syndrome with acute kidney injury consists of terlipressin and albumin. Norepinephrine and albumin is considered an alternative combination therapy to terlipressin. AASLD recommend that the combination of midodrine and octreotide and albumin should only be considered if terlipressin and norepinephrine are unavailable. Outside of medication therapy, liver transplant is often considered and generally advisable regardless of how well patients respond to medications. The use of renal replacement therapy holds a weak recommendation and is not a common approach to the typical patients with hepatorenal syndrome, though it does frequently occur. Moving on to the drug of interest for today's presentation, terlipressin was approved by the United States Food and Drug Administration in 2022 to improve kidney function in adults with hepatorenal syndrome with rapid reduction in kidney function. Terlipressin is an antidiuretic hormone analog that ultimately increases blood flow to the kidneys by reducing portal pressure and blood flow into the portal vessels, which increase effective arterial blood volume and mean arterial pressure. Terlipressin is administered via an intravenous bolus over 2 hours through either a peripheral or central line. Once terlipressin is administered, the line should be flushed. The approved dosing for terlipressin is an initial dose of 0.85 milligrams every 6 hours for 3 days. And then on day 4, the dose should be adjusted based on the patient's serum creatinine. If the serum creatinine has decreased greater than 30% from baseline, patients will continue the 0.85 milligrams every 6 hours until 24 hours after the patient achieves 2 consecutive creatinine values at least 2 hours apart of less than or equal to 1.5 milligrams per deciliter, or for a maximum of 14 days. If the serum creatinine has decreased by less than 30% from baseline, we would increase to 1.7 milligrams every 6 hours and continue until 24 hours after the patient achieves 2 consecutive creatinine values, at least 2 hours apart, less than or equal to 1.5 milligrams per deciliter, again, or for a maximum of 14 days. If, for whatever reason, the patient's serum creatinine increases from baseline, we would want to discontinue terlipressin in that case. Contraindications for the use of terlipressin include coronary peripheral or mesenteric ischemia, hypoxia, or worsening respiratory symptoms. Terlipressin can cause ischemia, and as such, use of this agent should be avoided in patients with severe cardiovascular conditions, cerebrovascular disease, and ischemic disease. Since patients with acute on chronic liver failure grade 3 have an increased risk of respiratory failure, these individuals should also avoid the use of terlipressin. Finally, terlipressin should be cautioned in patients with hypovolemia, since terlipressin will increase the risk for developing respiratory failure. As far as adverse reactions go, patients taking terlipressin will commonly experience hyponatremia, which may be preceded by fluid retention after 2 to 5 days of use. Patients taking terlipressin could also experience ischemic events or respiratory failure that are severe or life-threatening. Since liver transplant is an important component to consider in the treatment of hepatorenal syndrome, it's vital to understand that the use of terlipressin in these individuals may lead to adverse reactions that could make a patient ineligible for transplantation, including respiratory failure and ischemia. The benefits and risks of terlipressin should be weighed when deciding to use terlipressin in patients with an MELD or MELD score over 35, who are high priorities for liver transplantation. Terlipressin is also expected to cause fetal harm and should not be used in patients who are pregnant. Moving on to the agent we'll compare terlipressin to today. This is norepinephrine. Norepinephrine differs from terlipressin in that it's an alpha-beta agonist. Unlike terlipressin, which is administered over a 2-minute intravenous bolus, norepinephrine is administered via an intravenous infusion. For use in hepatorenal syndrome with acute kidney injury, an initial dose of 5 to 8 micrograms per minute is used. After 4 hours, the dose can be increased based on clinical endpoints, such as mean arterial pressure or improved urine output. Norepinephrine is a vesicant, and extravasation might occur. Thus, norepinephrine should be administered in a large vein when possible. Prior to using norepinephrine, the patient's volume status should be addressed to ensure patients are not hypovolemic prior to administration. Use in patients with hypoxia and hypercarbia should be cautioned, as should norepinephrine in patients with asthma or sulfa allergy, since this product contains sodium bisulfite. When choosing to discontinue norepinephrine, the infusion rate should be gradually reduced, while intravenous fluids are used to expand blood volume. In doing so, this helps to ensure that hypotension does not occur with abrupt discontinuation. While the frequency of adverse events from norepinephrine are not well defined, patients may be expected to experience bradycardia, cardiac arrhythmias, cardiomyopathy, peripheral vascular insufficiency, as well as some central nervous system effects like anxiety and transient headache. Finally, patients taking norepinephrine are more likely to experience dyspnea. When comparing items that should be monitored while therapy is ongoing, you'll notice there are more monitoring parameters to be concerned about with the use of norepinephrine compared to terlipressin. Specifically, monitoring parameters for norepinephrine include blood pressure, heart rate, cardiac output, intravascular volume status, pulmonary capillary wedge pressure, urine output, peripheral perfusion, and the infusion site for extravasation. Terlipressin's monitoring parameters include serum creatinine, oxygen saturation, acute on chronic liver failure grade, and volume status, including any signs and symptoms that the patient may be fluid overloaded or ischemic. Let's do a quick recap from some of the important concepts that we discussed in segment 1. In segment 1, we briefly discussed hepatorenal syndrome with acute kidney injury. We discussed that hepatorenal syndrome with acute kidney injury typically leads to poorer prognosis than hepatorenal syndrome with chronic kidney disease. This is mostly due to the fact that patients with an AKI are in a more severe and acute situation. The first step in treating hepatorenal syndrome is removing any agents that could be contributing to that AKI. This could be medications like diuretics or NSAIDs or ACE inhibitors. The first-line therapy for patients with hepatorenal syndrome with acute kidney injury is the combination of terlipressin and albumin. So let's recap some of the treatments we discussed and some of the important concepts about those medications. As we mentioned, the first-line therapy for hepatorenal syndrome with acute kidney injury is a combination of terlipressin and albumin. So let's look at terlipressin first. Terlipressin plus albumin is the first-line agent for HRS and acute kidney injury. It is given via an IV bolus, and it acts as an antidiuretic hormone analog. Important facts about this drug include that the approved dose from the United States Food and Drug Administration is an initial dose of 0.85 milligrams every 6 hours for 3 days. On that fourth day, you're going to be adjusting the dose based off the patient's serum creatinine. After terlipressin is administered, you want to make sure to flush the line after the drug is given. Some of the important safety considerations with the use of terlipressin were to avoid the use of this agent in patients with hypovolemia. It's also important to recognize that terlipressin should be avoided in patients with a MELD score that's greater than 35, and this has to do with the fact that liver transplantation is a common occurrence with this condition. The next agent that we discussed was norepinephrine plus albumin. This is the second-line treatment for this condition, and unlike terlipressin, is given via an IV infusion compared to an IV bolus. The initial dose in hepatorenal syndrome with acute kidney injury ranges from 5 to 8 micrograms per kilogram per minute. In terms of the safe use of norepinephrine, it's important to recognize that norepinephrine is a vesicant. And so we'll typically give this in a larger vein. And it's also important to recognize that when we're discontinuing norepinephrine, IV fluids should be used to expand blood volume first to prevent hypotension in these individuals. So again, this was just a quick recap of some of the important concepts from that first segment. We'll review some of this content later on. For now, let's look into the literature. Let's start off our review of the literature discussing one of the larger randomized controlled trials that compared terlipressin to noradrenaline. The study was published in Hepatology in 2020 and was authored by Aurora and colleagues. The study is titled Terlipressin is Superior to Noradrenaline in the Management of Acute Kidney Injury and Acute on Chronic Liver Failure. The research study was a randomized controlled trial conducted in a single institution, utilizing an open-label approach. In total, 120 subjects were recruited for the study, and authors sought to compare reversal of hepatorenal syndrome with acute kidney injury at day 14 and to compare early response of noradrenaline and terlipressin at day 4 and day 7, and to assess 28-day survival. Patients were evenly randomized into one of two groups, those taking terlipressin, given at 2 milligrams for 24 hours, or norepinephrine with a starting dose of 0.5 milligrams per hour. Patients were included in the study if they were diagnosed with acute on chronic liver failure. Specifically, they could have an acute hepatic insult manifesting as jaundice and coagulopathy, complicated within 4 weeks by ascites and or encephalopathy in a patient with previously diagnosed or undiagnosed chronic liver disease or cirrhosis and is associated with high 28-day mortality. Patients were excluded from this study if they were younger than 18 years, had decompensated cirrhosis, were receiving renal replacement therapy, had either a renal or liver transplantation, or had a history of coronary artery disease, ischemic cardiomyopathy, ventricular arrhythmia, peripheral vascular disease, chronic kidney disease, or obstructive uropathy. Eligible patients were randomized to receive either continuous infusion of terlipressin at 2 milligrams over 24 hours or norepinephrine starting at 0.5 milligrams per hour. The dosage of terlipressin was doubled every 48 hours in cases of no response to the maximum dosage of 12 milligrams over 24 hours. The dosage of norepinephrine was doubled every 4 hours at increments of 0.5 milligrams per hour up to 3 milligrams per hour to achieve an increase in the mean arterial pressure of at least 10 millimeters of mercury, or an increase in 4 hours urine output of 200 milliliters. All patients received standard management based on the hospital protocol and received plasma expansion with albumin for And the initial 2 days at 1 gram per kilogram per day, and then titrated as per signs of volume overload. Daily albumin was given in both groups until the end of the reversal of hepatorenal syndrome with acute kidney injury, or when there was evidence of volume overload, inferior vena cava, or requirement of renal replacement therapy. The patient's staging of their acute kidney injury in response to treatment were defined per the International Club of Ascites AKI criteria, and response was assessed every 48 hours. Patients were followed for 28 days, and authors utilized the reversal of hepatorenal syndrome with acute kidney injury at day 14 as their primary endpoint. A complete response was defined as a return of serum creatinine to a value within 0.3 milligrams per deciliter of the baseline. A partial response was defined as regression of acute kidney injury stage with a reduction of serum creatinine to greater than or equal to 0.3 milligrams per deciliter above baseline. And no response was defined by the patient receiving no regression of acute kidney injury. The authors also looked at early response to both norepinephrine as well as terlipressin at days 4 and 7, and the 28-day survival between the two groups. Safety as well between the two groups was also assessed in this trial. At baseline, the mean patient age was about 40 years in both groups, and the overwhelming majority of patients were male. Etiology was generally similar between groups and ranged from alcohol, reactivation of hepatitis B, drug-induced liver injury, and hepatitis E infection, with alcohol accounting for over 70% of patients in both groups. Stage 2 and 3 acute kidney injury were almost evenly represented in both groups, with a slightly higher percentage of patients with stage 2. Clinical markers suggest that patients have significantly impaired liver function, with a mean MELD score of around 33. At the end of the study, the primary endpoint, reversal of hepatorenal syndrome at 14 days, significantly favored therapy with terlipressin. In fact, 40% of the patients in the terlipressin groups experienced reversal of the hepatorenal syndrome compared to only 16.7% in the norepinephrine group. Response at day 4 and day 7 were also significantly higher in the terlipressin group. Overall survival was approximately 2.5 times greater in the overall survival group and those taking terlipressin. Results regarding renal replacement therapy also favored terlipressin, with 56% and 80% of the patients in the terlipressin and norepinephrine groups requiring renal replacement therapy, respectively. Importantly, there was no meaningful difference noted in the dose of intravenous albumin with both groups, receiving a mean albumin dose of 60 grams per day. Both groups also saw a meaningful difference from baseline in urine flow. Another item that was evaluated in the study was adverse effects. Diarrhea occurring more than 4 times a day was more likely to occur in the terlipressin group, with about 8.3% of these patients experiencing this effect compared to 0 in the norepinephrine group. Abdominal pain was noted by a small portion of patients in the terlipressin group, 1.6%, but no patients in the norepinephrine group. Serious adverse effects were noted in both groups. Terlipressin recipients experienced atrial fibrillation, cyanosis, and chest pain, while those taking norepinephrine were more likely to experience ventricular premature complex and hypertension. Study authors concluded that acute kidney injury in ACLF carries a high mortality risk. Infusion of terlipressin gives an earlier and higher response than norepinephrine, with improved survival in ACLF. In terms of limitations, it's important to note that patients included in this study have a MELD score above 20, Thus, the mortality benefits of terlipressin compared to norepinephrine may not apply to other patient populations. Trial weaknesses include the open label design, which increases the risk of bias when interpreting study results. While the study was the first published trial comparing continuous infusion of terlipressin with norepinephrine, the regimen is based on previous studies and is actually different from the approved bolus dose from the FDA. So let's look briefly at some of the available meta-analyses on this topic. First, a meta-analysis of randomized controlled trials by Pitre and colleagues was published in 2022. This meta-analysis included 26 randomized controlled trials of patients with type 1 or type 2 hepatorenal syndrome. Several treatment approaches were evaluated, including octreotide, norepinephrine, midodrine and octreotide, dopamine and furosemide, and terlipressin. The authors found a meaningful difference in the number of reversals and deaths with terlipressin versus placebo, as well as norepinephrine. Best and colleagues authored a meta-analysis that was published in 2019 that included 23 randomized controlled trials and included patients with type 1 and type 2 hepatorenal syndrome with decompensated liver cirrhosis. Interventions included both terlipressin and norepinephrine. When evaluating albumin and norepinephrine and albumin and terlipressin, recovery from hepatorenal syndrome was actually no different in this meta-analysis between the two groups. And actually, in fact, adverse events were determined to be statistically higher in the terlipressin group with a ratio of 0.5. The same was not true with serious adverse events, however. In looking at this, generally, older meta-analyses have generally suggested that there is no significant difference in mortality, reversal, or recurrence of hepatorenal syndrome, or even change in renal function between these two agents. However, a recently published meta-analysis demonstrated that terlipressin improves the reversal of hepatorenal syndrome and mortality. This meta-analysis included data from the CONFIRM trial, which was used in the fairly recent approval of terlipressin, and evaluated this agent versus placebo. While no significant difference between terlipressin and other vasoactive drugs was noted for the incidence of serious adverse events, norepinephrine was found to be associated with a lower risk of overall or any non-serious adverse events when compared to terlipressin. When putting this all together and thinking about where the use of terlipressin becomes clinically applicable, there are a few items to keep in mind. First, the positive data available for terlipressin in hepatorenal syndrome mostly relate to hepatorenal syndrome with acute kidney injury. But not every patient is really expected to benefit, especially including those with a serum creatinine that's greater than 5 milligrams per deciliter. Now, for those who might end up receiving terlipressin, it's important to monitor their oxygenation levels and respiratory function during treatment. For pharmacists, this medication's approval provides an opportunity to ensure prescribers are properly aware of the indications and dosage that's utilized for this drug. While some studies have directly compared terlipressin and norepinephrine, the FDA-approved dose of terlipressin has not been directly compared to norepinephrine. And so, norepinephrine truly remains a feasible option for hepatorenal syndrome with acute kidney injury, though guidelines favor terlipressin for first-line therapy. That is our review of the literature for today. Let's do a quick series of knowledge checks in order to recap some of the important points from today's presentation. Thank you. All right, everybody. That is the end of the content portion of our CE today. We're going to be jumping into doing just a couple of knowledge checks, and I'm going to do this in a different way than I've done in the past. So we'll be testing this out, and in testing it out prior, it's worked out well. So I hope that this will be a fun experience. So what I want you all to do is to select in the top of your screen, and then to annotate. And after you select that, a box will pop up. And in that box, you'll see a marker for stamp. And as you click on that, you should see a check mark stamp. I'll give you a minute to try to find that. If you are using the web browser version of Zoom, unfortunately, you're not going to be able to use this. What I'll have you do instead is type your answer choice into the chat, and I will put that onto the answers on the screen. So make sure everyone can kind of do that, and then I'll have you test that out now and see if you can put a check mark in this box. I'll start one. There we go. It's working for some folks. All right. Browser, please put that into the chat box. Yes. All right. First question we'll test this out with is just a demographics question. Today's presentation. A, from Infarm social media, from emails, through CE Impact social media website or emails, was it possibly word of mouth or some other method? Like most folks saw it from Infarm's social media and websites. So great. So it seems like this method is working. That's wonderful. All right. The next question is, please select what profession or area of practice best applies to you. Pharmacy jobs are out there. Okay. Our first knowledge check question is, what is first line therapy for hepatorenal syndrome with acute kidney injury? We're using the web browser version, or you're not having a whole lot of luck. Free to type your answer into the chat, and we'll put it on the screen for everybody. It looks like most folks have answered. Answered D, and so terlipressin plus albumin is the correct answer, the combination. Fantastic. With norepinephrine as a second line agent, we're looking at that with albumin as well. But terlipressin and albumin is going to be our first line agent here. Go on to our next one. Mechanism of action targets improvement in renal function, respiratory function, or none of the above. Most folks have selected renal function, and that is the correct answer here. Terlipressin is going to be mostly targeted and approved and helping that renal function out in patients in this acute. Third question is, what is the route of administration for terlipressin? IV bolus? Is it an IV infusion? Is it a injection, or is it oral? Like most folks are choosing IV bolus, and that's right. I do want to point out that I believe in the earlier in the presentation, I believe I said it was administered over 2 hours. I think later on I said 2 minutes. It is administered over 2 minutes, and that is important. So the fourth question is, what day should terlipressin dosing be considered for adjustment? Day 3 or on day 4? On this, and the first 3 days are receiving the same dose, and then we'll titrate it based off their kidney function. Is included in the boxed warning for Terlipressin, and select all that apply. Right. So this one was a bit of a trick question. All of these are side effects for Terlipressin. The only one that's technically included in the box warning is respiratory failure. So respiratory failure is something that we got to be cautious with and certainly monitor as patients are taking this medication. Number 6, which medication is considered medications? Like Terlipressin, albumin, norepinephrine, or none of these? Like most people have chosen norepinephrine as the best, and that's correct. Norepinephrine is a vesicant, so cautious of. With norepinephrine. Like most people are identifying that we do have a numerous monitoring parameters that we can consider with norepinephrine. Urine output can also be considered with norepinephrine as well. You'll see some resources that suggest that urine output is something to be. Number 8, the dose used in the study by Aurora and colleagues that we covered today used the FDA-approved dose of terlipressin. So is this true or false? More folks have selected false. Correct. The FDA-approved dose was not utilized in this study. This study actually looked at an infusion over 24 hours when we compared it to norepinephrine specifically. In getting terlipressin's approval, that study was a randomized controlled trial that looked at terlipressin versus placebo, and that's where they utilized that 2-minute slow IV bolus. So the actual approved dose is that slow IV bolus. Patients with which of the following were excluded from today's study? That was a harder one, so I will go ahead and check those off. So it is decompensated heart failure, so the data don't apply to those individuals. Then the individuals with peripheral vascular disease were also excluded. Interestingly enough, ventricular arrhythmias were excluded. There was no mention of atrial fibrillation or history of hypertension. So A and D were excluded from this study. All right, number 10 is which is false concerning today's study? Was it that all patients also received albumin? Patients were mostly male. The mean age was about 50 years in both groups, or that it was a single center study? Which of the following answers is false? Mark it on here for us. I think that one was a trickier question too. So actually, yeah, most patients in this study were between the ages of about 38 to 40. So they were certainly a bit younger. Older patient population not well represented. And certainly with the exclusion criteria identified, that's understandable. A younger patient population. Of renal syndrome with acute kidney injury, not ASK, at day 14 in each group. So this is going to be a trickier question. We'll see if anyone has memorized any numbers that they saw today. This is the reason that we're doing this. I just wanted to make sure to highlight some of the key differences in this study. There's a lot of material we discussed, a lot of material we talked about. And so the differences between these two groups, and this is the primary endpoint. Day 14, reversal of AKI was, 40 to 17%. So 40% achieved the primary endpoint in terlipressin and 17 in norepinephrine. All right, in today's study, we have 2 more questions. So in today's study, which represents the overall survival numbers? So again, with the overall survival data that came from this study? And if you don't know specifically, which one do you think it might be? So actually, sounds like a pretty good option. It is actually A. It is actually A. Terlipressin had a much better overall survival in our study today than norepinephrine did. Pretty significant. And finally, available meta-analyses disagree that terlipressin is superior to norepinephrine. True. If anybody's on team false, it is true. All right, so more folks answering in to A, that's correct. There are a couple meta-analyses that align with the study that we've looked at today. Some of these are older, but more recent, robust meta-analyses tend to indicate that terlipressin may be more effective than norepinephrine. Certainly, the study we looked at today specifically, which was one of the larger studies that have compared these two agents in a randomized controlled fashion. And so with that in mind, I think it's certainly important to take that into account, as well as the fact that our guidelines suggest that terlipressin is, with albumin, is our guideline-directed first-line therapy. So excellent. That is the